and she's known to pioneer the radiosurgery in the United States and also around the world. So I'm looking forward to see what she has prepared for us. The talk is on the game-changing technology in radiosurgery. Lily, are you happy? Are you ready to go?
Thank you very much for the kind invitation. Congratulations on a terrific meeting, and I feel very privileged to be part of some of the spine innovations that we are discussing this morning. I will pull up my presentation. Is this visible to everybody?
Yes, looks good.
Okay, excellent. So the title of my presentation today is Spine Radiosurgery, the 21st Century Game Changer, and it focuses on spine tumors and how our culture has very much changed in the management of what used to be extremely challenging cases, where with multimodality therapy, we have now distilled it to much more manageable patient care and excellent outcomes. Let me just, sorry, my slides aren't advancing. There we go. So spinal metastases, we know that systemic disease progression rather than spine metastases directly is typically the overall determinant of a patient's life expectancy. So any interventions we do have to have a high level of efficacy as well as minimal global effect on the patient. And these are extremely valuable and desired strategies. It needs to be multidisciplinary and integrated therapies, and we need to treat both symptomatic and asymptomatic spinal metastases, and this is of increasing clinical importance. What are our goals in treating spine metastases? We have to either preserve or restore patient ambulation, maintain patient bladder control, and provide pain relief, which is essential for patients' quality of life. The 21st century has ushered in several ways of addressing spine metastases. And the first of these is almost now 2 decades ago with the Patchell study in Lancet that was published that did a direct comparison of decompressive surgery in the treatment of spinal compression followed by external beam radiation and compared it to external beam radiation alone. It used to be that when patients had spinal metastases, we as surgeons never used to see these patients, but rather they would go directly to the radiation oncologist and get conventional radiation, and that would be the end. And often they would have poor outcomes, poor quality of life, and wouldn't be candidates for further systemic therapy because their performance status was so low. This was a randomized prospective study, and it was stopped at the time of interim analysis because there was such a massive advantage in terms of decompressive surgery first over just external beam radiation. The surgical group fared better in terms of retaining ambulatory rate, regaining ambulation, neurological examination, their survival was prolonged, their analgesic use dropped, as well as their corticosteroid use dropped. So there was improvements in neurological recovery in patients with high-grade cord compression. It restored spinal stability. However, everybody in this room understands that metastatic tumors are not typically resectable for cure, and with conventional radiation, we do not achieve durable tumor control because 2 reasons. We're unable to deliver effective dose required for radioresistant tumors, such as renal, sarcoma, colorectal cancer, and there are dose limitations at recurrence. So many times what was given at the first treatment, at recurrence, we can give even less, so that with conventional radiation, if patients recurred, the even less dosing provided no therapeutic input in these patients. So enter the second game changer, and by now many of you are familiar with the term spine radiosurgery, And essentially, it is a delivery of accurate and conformal radiation to a tumor in 1 to 5 sessions. That's the classical definition of radiosurgery. It's 1 to 5 sessions. I tend to describe this as a glove fitting a hand. I'm originally Canadian, so I talk about a glove instead of a mitten. This has to be very precise around the tumor, not splashing to the adjacent organs and structures, and most specifically, having very steep dose fall off, and therefore very little associated adjacent dose to the spinal cord or thecal sac. The dose gradients result in a decrease of radiation dose of nearly 20% for every millimeter drop off from the target. It is twice as effective as conventional radiation and typically requires a partnership between a neurosurgeon, a radiation oncologist, and a radiosurgery physicist. And how I describe it to my patients is that as a neurosurgeon, I know the anatomy and therefore do the targeting, and the radiation oncologist delivers the dose of radiation, and the physicist keeps us all honest. So I say that I'm the spotter, the radiation oncologist is the sharpshooter in terms of targeting, but this is why it requires a multidisciplinary integrated approach. Who are candidates for spine radiosurgery? Patients with tumor progression or pain, those that have mild to moderate spinal cord compromise. The novel part of this is also that these may be previously irradiated lesions, unlike with conventional radiation where we tend not to redo treatment. They are residual or recurrent tumors after surgical therapy, those that are difficult surgical approaches that we can't get at in terms of surgical decompression. And I have a case to show you a little bit later with one of those difficult surgical approaches and a lovely outcome with spine radiosurgery. Patients that have a relatively short life expectancy. If a patient's life expectancy is 3 months, you don't want them to spend 2 months of their life expectancy in the ICU. And this therapy is done completely as an outpatient, and many patients achieve significant pain relief with the therapy as early as 1 week post-treatment, and some even with a shorter time interval. Those that have significant medical comorbidities that are not candidates for open surgery are also excellent candidates for spine radiosurgery. Who do we not treat with spine radiosurgery? If the neurological deficit is too rapidly progressive, these are not candidates. For example, I will not offer spine radiosurgery to patients that are not able to stand independently. So any patient with 3 on 5 or less is really not a monotherapy radiosurgery candidate. Those that have cord compression with bone or disc fragments, obviously those structures don't respond to radiation. If they don't have a known cancer tissue diagnosis, obviously you don't want to be irradiating tuberculosis. And those that have an overt spine instability, because in spine tumors, it is 2 things that are important: the oncological aspects of a patient's disease, as well as the mechanical aspects of the patient's spine stability. This shows a number of studies over time. The size of the dot indicates the size of the trial, and there's not a lot of cancer therapies out there, no matter what they are, that have a 70% or greater response rate. For most of us that do spine radiosurgery, our response rate is 80 to 90% local control. And so this is a very gratifying neuro-oncologic practice to have. This is our own data through the clinic of 108 patients who we treated prospectively and monitored prospectively in terms of pain relief and quality of life. And you see that statistically significant in the top corner here, statistically significant improvement, here we go, at 1 week was seen from baseline with brief pain inventory, a formal pain scoring system. And this was persistent up to 9 months post-treatment when we no longer were following these patients. Their pain medication also markedly decreased. You see the population here at baseline that took no analgesics, and that rapidly rose. And those patients, narcotic use with morphine equivalents markedly dropped. If we look at quality of life, Not all aspects of quality of life were impacted by spine radiosurgery, which obviously makes sense because you wouldn't expect financial difficulty to improve with spine radiosurgery, which is one of the quality of life measures. But the metrics that did improve are consistent with the impact, which is pain, insomnia. If they don't hurt, they sleep better, and constipation. If they're not taking opioids, then their constipation is markedly improved. But these three factors, even as little as treating one vertebral body with this therapy, had a marked and clinically significant persistent improvement in quality of life. For those of you that haven't seen what this looks like, here's one of our gentlemen just getting ready for treatment. Two therapists are getting him on the table. You see him poised to get on the table. This is my radiation oncology partner, Sam Chown. We do the vast majority of cases. We started this program in 2006, and since then have treated thousands. We're approaching 3,000 cases of spine radiosurgery. We're positioning him here. We have an open face mask, even for those patients that are claustrophobic. They tolerate the open face mask, and you can see him well immobilized because it goes with facial recognition. And here he is comfortably positioned, and you can see a mid-cervical region vertebrae is what's being targeted in this gentleman who has renal cell carcinoma, a radioresistant tumor. He looks pretty relaxed, pretty comfortable. And here he is 15 minutes later. His treatment is complete. He's getting off the table and going to lunch with his wife. There are no surgical treatments that I do that allow patients to have this kind of quality of life, and certainly no tumor surgeries where the patient pops off the table 15 minutes post-treatment and can pursue their normal activities. So the major potential benefits of radiosurgery are short treatment time in an outpatient setting with no formal recovery time, good symptomatic response, 85 to 90%, positive impact on quality of life with successful tumor control, minimal risk of radiation myelopathy. The data we quote is 0.6% or 6 per thousand risk of radiation myelopathy, which is extremely low risk of toxicity for any kind of treatment, and tends to be very effective even with those that are conventionally radioresistant, such as melanoma, sarcoma, and renal cell carcinoma. This is a case that I'd like to share with you. This is a 52-year-old man with a sudden severe lytic destructive mass, a severe neck pain with imaging demonstrating a lytic destructive mass at C2, and he underwent a synchronous renal mass biopsy that revealed renal cell carcinoma, which is, as everybody knows, extremely vascular, challenging tumor to resect. The decision was made not to go after the primary tumor, but simply to offer posterior neck stabilization. But obviously, as you can see, he had persistent cord compression on the axial stir images. He was offered radiosurgery treatment, which is in the center panels in sagittal and axial view. And 2 years later, and now actually, this is an old slide. This gentleman is now 4 years out. He continues asymptomatic. You can see marked shrinkage of the tumor. He's had no further interventions, and the MRI demonstrated cord decompression. And in fact, the marrow is heterogeneous, compatible with a treated metastases and somewhat new bone laydown. So this, he needed stabilize, again, mechanical plus oncological importance. He needed stabilization, but for the oncological treatment, it was done with radiosurgery only. Dose matters. And this brings us to the third game changer that I'd like to talk about. So it's really important. The higher the dose that you can deliver to the involved area, the better and more durable the control is. The problem is that the spinal cord is a serial functioning unit, so that if you knock things out at C6, everything distal to C6 is impacted. Unlike parallel functioning units such as kidney and lung, where there's multiple redundancies, so that if you knock out a portion with therapy, there is still other sub-aspects of the organ that can take over. So the key to safety in terms of spine radiosurgery is carefully constraining the dose adjacent to the spinal cord, constraining the radiation dose. So this led to the third game changer, which we refer to as separation surgery. Well, what is separation surgery? It is essentially the separation of the tumor from the dural sac, decompressing the spinal cord in order to reconstitute the spinal fluid space. Tumor in the vertebral body and parasagittal region does not need to be resected, thereby reducing the surgical time, the blood loss, and morbidity. You just need to make space between back of tumor and adjacent neural structure. The decompression provides a safe margin to deliver cytotoxic radiation dose to the tumor within the constraints of the spinal cord, and the stabilization depends on the degree of instability, but usually we do minimal stabilization with pedicle or lateral mass screws, 2 above and 2 below, and can add cement augmentation if there is poor bone quality. So the surgical time is relatively brief. It is for mechanical stabilization and separation of tumor, and anterior reconstruction is rarely required. So surgery becomes now an adjunct to the definitive oncological procedure of radiosurgery. Separation surgery, this was a study out of Memorial Sloan Kettering, and again, higher dose leads to better outcome after separation surgery. This is another important study that we looked into, and we now treat a mechanical construct as an organ at risk, if you will, because when we looked back, we looked at instrument failure, and there was 43% of instrument failure in the group that received conventional radiation after surgical decompression, as compared to getting radiosurgery. There was 0% instrument failure in the radiosurgery group, and there was bony fusion in 50% of the radiosurgery group where a bone graft had been used, as compared to only 17%. So ideal combination therapy would be surgical separation, mechanical stabilization, followed by radiosurgery rather than conventional radiation treatment. This series looked at hardware failures in the face of radiosurgical treatment, and again, the hardware failure rate was extremely low when you use radiosurgical treatment as compared to conventional radiation. So since 2000, there has been a rapid expansion of spine radiosurgery cases, and we looked across 12 high-volume institutions for an international survey that we did to see what was happening across these institutions over time. As you can see, there has been a trend in metastatic cases. Here in this first 2000, there was only a low rate of the gray column, which is renal cell carcinoma, which is very radioresistant, and we weren't really treating very much of this with conventional radiation. And in fact, these were the ones that if there was one vertebral body, we even tried to do a metastectomy in these. But over time, these radioresistant pathologies remain very relevant. And this has brought to the fore increased awareness of radiosurgical treatment to what used to be extremely challenging cases, which now become average treatment cases. Now, what are novel radiosurgery trends? Evaluating the role in oligometastatic disease, which are often asymptomatic lesions. Oligometastatic means metastatic disease is present in a limited number of anatomic sites. And the thinking about oligometastatic disease is that if you can remove the met, first, this thinking became so with surgical resection of liver mets, lung mets, and sarcoma, etc. If there's a limited amount of disease and you can ablate that metastatic site, you essentially revert the patient to a pre-metastatic condition or grading. And so this approach of less than 5 sites, if you have a chance to cure or control the disease in prior metastatic patients with some kind of ablative technique. This was proved in a randomized study where you can see the control group has much lower control rate as compared to those that get radiosurgical treatment. So one of the groups that I get referred an awful lot of is patients with oligometastatic prostate cancer. These patients have usually asymptomatic disease, but we are able to give prolonged life expectancy and essentially revert them to a non-metastatic state, control their PSA, control their function, etc., by a 15-minute outpatient procedure. Huge, huge gain in terms of radiosurgical management. Here's a case of an oligometastatic case, and you can see 1 year post-radiosurgical treatment in this L1 lesion. There is fatty marrow replacing the previous osseous metastases to suggest that there is new bone laydown in the area where the tumor mush had been killed with radiosurgical treatment. So radiosurgery is safe, effective, with durable symptomatic response. It is important for oligometastatic disease and radioresistant disease, and as our experience grows, with the use of radiosurgery as a post-op adjuvant to surgical resection of spine tumors has become less aggressive, and this paradigm has led to more minimally invasive open surgical treatments. But just a reminder as I'm closing that spine tumor programs are inherently collaborative, and this is essential for a program to succeed. We have a weekly spine tumor board, which is the anchor of all of our work. And we provide recommendations. This is the demographic of who attends this tumor board. We have surgeons, radiation oncologists, medical oncologists, etc. We provide recommendations, and the plan is recorded in a database. And then we call the patient and let them know that the team recommendation is X, and they get a 40 for 1 opinion. And now with virtual visual conferencing post-COVID, this has become even higher in terms of attendance and participation. Here is spine tumor board cases presented over time with a massive increase. These are the pathologies we see. While METs are the most common spine pathologies, the more challenging discussions affect other pathologies, including nearly 20% of non-tumor pathology, with our neuroradiologists helping us to distinguish and triage cases appropriately in terms of management. So none of us work in silos anymore. So radiosurgery demonstrates clinical value, often in comparison to long-standing, well-accepted treatments. It's non-invasive, and it completed in an outpatient setting, which is great for patients from a rural setting or far from a treatment center. There is minimal disruption of their systemic treatment. They can go on to systemic therapy within 1 to 2 days of treatment, allows patients to resume their normal activity as quickly as possible. I've had a patient get off the table, go to the airport, fly to Orlando, and get on a cruise ship. So patients tolerate this extremely well. They decrease their medication, decrease their retreatment. Therefore, it reduces health system utilization, minimizing costs. So there's advantage from the patient, from the healthcare system, and society overall, although continued studies and clinical research are required. Why is this important? I'd like you to meet Cynthia H. She's a retired manufacturer worker and a grandmother. She was diagnosed with stage 4 non-small cell lung cancer. Her neck hurt so badly, just brushing her hair or flipping it off her face became unmanageable, so that she cut her long hair. She underwent spine radiosurgery, 1 fraction C1, C2, with resultant complete pain relief and tumor control 4 years ago. Her hair is now back to waist length. She is pain-free. She chases her grandson and travels to watch her youngest daughter play college softball. These are our patients who deserve our best in terms of care. So remember the patient when we're offering them spine tumor treatment. I'd like to thank the amazing team that I work with in order to deliver this therapy to our patients, and thank you for your attention. Any questions?
Thank you so much, Lily. Thank you so much, Lily. I think we're gonna leave the questions for the end of the session. But if there is anybody that's pressing now, please please go ahead, or please put a question in the chat, and then we will be happy to answer that. Other than that, if you don't have questions, we will have questions for you at the end because we have prepared MCQs for you. You have to answer these MCQs back to us in order to to get your certificate. You should not be worried if some of your questions are answered not correct. We will send you the right answers, but you should make the effort to try to answer these questions, because this is the requirement for getting your certificate from Royal College of Surgeons. So be aware, we will share a link at the end. Lily, many thanks for amazing presentation and for your participation today. And if I don't see questions now in the chat, but I will forward to you, and then we'll communicate later with the people asking in case there is any. Thank you so much.
Thank you. Thank you for the invitation. Thank you, everybody, for your attention.
Pleasure. And now we will